Hello and welcome to the Peer Exchange. We're going to discuss recent updates in practice guidelines, early diagnosis, and management of prostate cancer. My name is Raoul Concepcion. I'm a practicing urologist specializing in urological oncology, and I'm also the Director of Clinical Research at Urology Associates in Nashville, Tennessee. I'm also the immediate past president of the large urology group Practice Association. I have the distinct privilege of moderating today's discussion. We'll discuss the many new treatments for castration-resistant prostate cancer. Our goal is to provide urologists with a range of expert perspectives on current challenges that affect your patients and your practice. For today's panel, I am joined by leading experts and frontline practitioners with a wide range of experience in these areas. David Albala is the medical director of Associated Medical Professionals, and he's also the chief of urology at Crouse Hospital in Syracuse, New York. Dr. E. David Crawford is at the University of Colorado Health Science Center in Denver, Colorado. Dr. Vahan Kassabian is the medical director of Georgia Urology in Atlanta, Georgia. Dr. Stephen Finkelstein is the national director of 21st Century Oncology, TRC, in Scottsdale, Arizona. Dr. Steve Freedland is Associate Professor of Urology at Duke University in Durham, North Carolina. And Dr. David Quinn is Associate Professor of Medicine, Division of Cancer Medicine at the University of Southern California in Los Angeles, California. In this first segment, we are going to discuss recent updates in clinical practice guidelines. Let's begin this section with a review of the most recently published clinical practice guidelines and consensus statements regarding prostate-specific antigen, or PSA, screening. So let's begin this discussion given that at the most recent American Urological Association meeting last May, that the AUA came out with some new guidelines on PSA testing. So, Dr. Albala, given what's transpired over the past few months, give us your impression on the most guidelines, takeaways, and what we should be looking at in terms of what the AUA has recommended.
So the AUA has changed its guidelines just recently, and these were presented at the national meeting that we had this past spring. Traditionally, the guidelines have been men age 40, if they're African American or a family history of prostate cancer, would be screened with a digital rectal examination and a PSA. The guidelines now are essentially looking at changing this and making those patients from age 55 to 69 the ones that would be screened that are essentially asymptomatic and don't have any risk factors, if you will, for prostate cancer.
Dr. Freedland, you were intimately involved in this statement, so what's your take?
Yeah, so I was actually on the guidelines panel, though obviously here giving my own opinions, not formal guideline opinions. It was certainly a very interesting process. It was a 2-year, very rigorous process. And really, the benchmark that we required was data showing improved survival, prostate cancer specific survival, that doing this test will save your life. And, you know, really the strongest data for that comes from the European data, the European randomized study of screening for prostate cancer. And in the core group, 59 to 69, PSA testing done every 4 years, which is kind of different than what we're traditionally been doing here, actually reduced prostate cancer deaths. The data for the 40 to 54-year-olds, which I think has really been some of the most controversial data, wasn't studied. So we don't know from a formal data-driven point of view what to do for those men. So in the absence of data, and there's known harms to screening, picking up cancers that don't need to be, that get treated, ED, complications, that we can't really make a recommendation given the absence of data. There's certainly data that getting a PSA test at that age, 40, is prognostic, but it doesn't mean by knowing that information, I can do something to save someone's life. Maybe we can, maybe we can't, we don't know.
I think what created a little bit of a firestorm with this was given the fact that this followed so closely on the heels of the United States Preventive Services Task Force recommendation that basically gave PSA testing a D recommendation. And again, I think many in the field basically felt that what the preventive task force services did was that they tied the fact that they felt there was overtreatment of localized prostate cancer and tried to tie that back to early diagnosis.
So we had a lot of discussion about that on the guideline panel, and our certainly the sentiment of the group and my sentiment as well is we do need to clearly separate diagnosis from treatment, is what we need to do. But when you look at the reality of what's actually being done, they are synonymous. Over 90% of patients are treated, even with low-risk disease. So we need to come up with a guideline for today's practice, not what should we be doing in the future 5 years from now when they're separated, but given that they are synonymous, how can we reduce harms while still trying to preserve as much of the benefit as possible?
I also think it goes back to the discussion with the physician, that each patient is individual. They need to have a discussion with their patient. If it's a big concern and a psychological concern, then getting a blood test and just understanding what that blood test is, much like we get a cholesterol or a CBC or other blood work, trying to understand what that test means, and then having a discussion with your physician to try to recommend a particular treatment if it's elevated, whether to go with a biopsy or whether to just follow the PSA.